The topic of my presentation is local anesthetics in dentistry, and this presentation is based on Dr. Daniel Haas's article on an update to local anesthetics in dentistry that was published in 2002. So all the information is taken from that paper. So just as a brief introduction, pain control by local anesthesia is a critical aspect of clinical dentistry. On average, a dentist will inject about 1,800 cartridges of local anesthetic a year in Canada. Over 800 million cartridges are administered every year in the USA. Therefore, every clinician should have the expertise in local anesthesia. So a bit about the pharmacology of local anesthetics. So local anesthetics prevent the propagation of action potentials in nerve cells. Therefore, pulpal and tissue sensation cannot be perceived by the brain. So this is through the blockage of sodium ions into sodium channels, so preventing the propagation of action potentials. A bit more about the pharmacology. So most local all local anesthetics share some common molecular structure properties. So they contain a lipophilic group, an amide or ester group, and a carbon chain, which is linked to a hydrophilic group. So structurally, all local anesthetics have this in common, and they're classified based on whether they have an amide or an ester group. So the amides include lidocaine, bupivacaine, mepivacaine, prilocaine, and articaine, and the esters include procaine, which is actually no longer available in cartridge form, as well as topical benzocaine. So a couple of terms, onset is how quickly an anesthetic begins to work, and duration of action is how long an anesthetic is effective. So the onset and duration of action are influenced by factors that are listed in this table below. The pH of a tissue, which is influenced by infection, is very important in determining the onset of a local anesthetic. So a lower pH means that it will be harder to achieve profound anesthesia. Clinically, there's no significant difference in the pK of different amides, with the exception of bupivacaine, which has a slightly higher pK and a slower onset, but pK of drugs are also very important. Clinically, the proximity of the needle deposition to the site is also very important, and this is why infiltration is usually more rapid than a block such as a Gauge-Gates, which has a relatively slow onset. Thin fibers are also anesthetized more rapidly than thick fibers, and higher concentration as well as higher lipid solubility will also lead to quicker onsets. So some more points about pharmacology. Duration of action also depends on whether a vasoconstrictor is added to the local anesthetic cartridge. Local anesthetic will cause vasodilation, which leads to rapid diffusion. And vasoconstrictors can counter this effect to a certain extent by keeping local anesthetic at the injection site and facilitating a longer duration of action. Typically, blocks will last longer than infiltration, and soft tissue will last longer than pulpal anesthesia. Bupivacaine is also a unique anesthetic. It has a longer duration of action than other amide anesthetics. So a bit about the biotransformation, which is the breakdown of local anesthetics. So esters are typically biotransformed by plasma cholinesterase. So therefore, if a patient has a deficiency in this enzyme, they're expected to metabolize and ester their anesthetic at a much slower rate. And amides are biotransformed in the liver primarily. So a clinician should be concerned about the biotransformation of an anesthetic in a patient with a severe liver function damage. So in a patient with hepatic dysfunction, total dosage is a concern due to limited biotransformation issues. So management considerations include, for example, doing quadrant dentistry to reduce the overall total dosage in these patients and to reduce any potential for some toxic effects. And prilocaine is an amide that is an exception to the rule above. It's metabolized in the kidney and plasma, and one of its metabolites can actually lead to methemoglobinemia. So this table is just showing some of the adverse reactions of local anesthetics. So adverse reactions are very rare, but because of the high number of injections that are given every year, they do sometimes happen. So anxiety-induced adverse reactions are the most common by far, and they can manifest as psychogenic adverse reactions. So for example, syncope is the most common, hyperventilation, nausea and vomiting, alterations in heart rate or blood pressure, as well as mimicking of an allergic reaction are the most common. An allergy to epinephrine is basically impossible. It's usually one of the added components or preservatives to local anesthetics that will typically cause the allergic reaction. So for example, metabisulfite is if a patient's allergic to a sulfite, then they could be allergic to the preservative, or methylparabens. And typically the amide allergic reactions are very rare. Esters is a bit more common than amides. Toxicity may also result from a single inadvertent intravascular injection. So that's why it's very important to aspirate before administering an injection to ensure that there's no intravascular issues, or as well as repeated injections, which can lead to high blood volume of the anesthetic. Adverse reactions, an adverse reaction called methemoglobinemia can also occur, where excess metabolites can manifest as a cyanotic appearance, which is not alleviated by oxygen, as well as paresthesia can also occur, but this is much more common following extractions, but it's also possible after non-surgical dental work. So this table just is the recommended doses of the most common local anesthetics that are administered. I just want to highlight articaine, bupivacaine, lidocaine, mepivacaine, and prilocaine, especially lidocaine because it's one of the most commonly administered ones. So the maximum dose is recommended to be 7 milligrams per kilogram in an adult. And this makes up to about 500 milligrams total. And it's approximately 13 cartridges. So to avoid toxicity, it's important to stay within the recommended doses of local anesthetic. Okay, so a bit about the vasoconstrictors that are added to local anesthetics. So they're invaluable to local anesthesia in dentistry. They improve the depth and duration of local anesthesia. Without them, local anesthetics have a very short duration intraorally. They're usually more effective for infiltration in vascular areas than mandibular blocks. And the formulations of epinephrine are 1 in 50,000, which is the most concentrated, 1 in 100,000, and 1 in 200,000. So the mechanism of action of vasoconstrictors are that they stimulate the alpha-1 receptors in mucous membranes, as well as the beta-1 receptors in the heart, which increases heart rate, contraction, and oxygen consumption, as well as the beta-2 receptors in skeletal muscles, which causes vasodilation. So the recommendation is to stay below 0.04 milligrams in patients that have cardiovascular disease. And this is a guide, especially patients that have a history of ischemic heart disease and a recent myocardial infarction. So this table is just showing some potential treatment modifications that you can make if you have a patient that has some of those issues that I just listed. So you can monitor the blood pressure and heart rate preoperatively. You can minimize the administration of the vasoconstrictor. monitor the blood pressure and heart rate 5 minutes after injection if you think you need to. You may re-administer the vasoconstrictor if blood pressure and heart rate are stable. It's important to continue to monitor as required and consider limiting the vasoconstrictor to 0.04 milligrams for epinephrine, and avoid the high concentration formulations, and never use epinephrine impregnated retraction cord. And this table is just showing some potential drug interactions. So because the vasoconstrictor targets those receptors that I talked about, they can compete with other drugs that target those receptors. So it's important to note which drugs could target the same ones. So I'm not going to go into too much detail here, but I'm just going to mention the non-selective beta blockers, certain tricyclic antidepressants compete, as well as the general anesthetics and cocaine. Okay, so I just have a sample calculation of how to calculate how much epinephrine you're administering. So say, for example, you have a 2% cartridge of 1 in 100,000 epinephrine. This equates to approximately 0.01 milligrams per milliliters of epinephrine. So assuming one cartridge is 1.8 milliliters, you just multiply the 1.8 milliliters times 0.01 milligrams per milliliter, and you get 0.018 milligrams per cartridge of 2% lidocaine containing 1 in 100,000 epinephrine. So a bit about topical anesthetics. So these are used to minimize the sensation of the insertion of the needle in the patient. Their effectiveness in preventing pain due to the injection has shown to be equivocal. So some patients benefit from it, some patients don't find a difference. And up to 20% benzocaine gel is typically used, or lidocaine 5% ointment, or 10% spray. And then one of the last points I want to make is just to touch on special population considerations. So local anesthetics can be administered to pregnant and lactating women, but one needs to just consider that they need to aspirate before injecting, just to minimize any likelihood of intravascular injection. So lidocaine and prilocaine are the preferred local anesthetics because they're category B according to the FDA due to low concentration formulation. And we don't have any major concern with the vasoconstrictor here. With respect to pediatrics, the main concern is overdose. So it's important to calculate the maximum number of cartridges that can be administered to children, which is based on their weight. So 2% lidocaine is the ideal anesthetic to administer to children. And again, there's no concern with vasoconstrictor here. And then with the elderly population, there is no significant difference in administering local anesthetics to regular healthy adults or elderly patients, but it's important to keep in mind that this population is at higher risk for cardiovascular issues. So you want to minimize the vasoconstrictor where necessary. And elderly often have some sort of liver function compromise. It's just natural as you age. So it's important to stay below the maximum dose to avoid toxicity. And then I just have a sample calculation for children. So if you have a 15 kilogram patient and you're giving them lidocaine, so you can multiply to get the maximum dose, 7 milligrams per kilogram times 15 kilograms, which gives you 105 milligrams maximum. And then 2% lidocaine contains 20 milligrams per milliliters of lidocaine. So if you just divide 105 by 20, you get 5.25 milliliters. And then to calculate the maximum number of cartridges you can give them, you divide that number by 1.8 and you get 2.9 cartridges, which is the maximum. So in conclusion, all local anesthetics used in dentistry are efficacious. The decision of which to use is based on clinical judgment and knowledge, and we must consider the duration of action, medical history, and drug interactions. Vasoconstrictors are invaluable. However, we must consider the patient's medical history and consider if they have any cardiovascular issues and possibly limiting the vasoconstrictor that we give them. And this is my reference. So thank you.
Wow, thank you very much, Dr. Saati. That was very thorough. We're gonna right now move, if you guys have any questions and would like to see if you can add them up to the chat and we will read them to Dr. Saati. In the meantime, we'll have a very, if Dr. Saati allows me, right, we can have a very, how are we gonna say it? A very conversation about this. You know, you've mentioned there's, you know, I always say about the 4 properties of any local anesthetic. Do you mind if you just summarize them again for us? Which and what are the factors that can influence them? When I talk about that, we're talking about onset, duration, potency, and elimination.
Yes. You want me to talk about that more? Or?
That's my favorite question.
I think I talked a bit about onset and duration a bit, but yeah, so elimination, sorry?
Onset has got the degree, it depends on the degree of the binding of the local anesthetic to the proteins, correct? And obviously the vasoconstrictors that has been used.
Yes.
Something that was mentioned?
Sorry?
Was that what was something that it was mentioned, right?
I didn't mention it directly, but yeah, you're correct.
What about potency?
Potency is how much of a dosage you need to cause a certain effect.
So potency is related to the degree of the penetration of the local anesthetic into the phospholipid layer, right? So this is how it's an elimination. Obviously, we've discussed with amides being in the liver and esters being in the plasma of the blood through the pseudocholinesterase. Now, imagine if somebody has liver problems. Do you think we should give him esters?
Well, it depends, because if they have liver problems and they have issues with the protein production and breaking down local anesthetic, yeah.
That type of enzyme that it's pseudocholinesterase,
yeah,
it's in the liver. So that's like a tricky one, right? So he said, oh, okay, well, if it's in the plasma, can I give it? The answer is no, because that pseudocholinesterase is produced in the liver. So if your liver is not functioning well, you're not going to be able to produce up pseudocholinesterase. Yeah, absolutely correct. And you've mentioned something nice about the prilocaine, the articaine being a mixture between amide and ester. You're absolutely correct. And probably another thing that I want to touch base on that I know that I've discussed with you before is the reversing agent. Do you remember what's the name of the reversing agent, or if it was any?
Was it called Auraverse? I can't remember.
Oh, exactly, it's Auraverse,
Okay.
right? So it's right. Exactly. So it's called Auraverse, absolutely. And how does it work? Do you remember how does it work?
Not sure. Does it neutralize?
It's an alpha one. It just basically vasodilates. So the local anesthetic will comes out quite easily. It's simple as that. It's alpha 1, right? And what else we need to discuss in this chats? We have a lot of chats. Okay, does anybody have any questions? Okay. Because I can carry on talking forever if you guys are not going to ask questions. So Dr. Tamim have a good question. He says, I have a question regarding the breastfeeding. Is there any special consideration before breastfeeding after taking local anesthetic?
No, I think there's no, it depends on which one they're taking, but I think I mentioned it was lidocaine and prilocaine are category B, so they're considered safe. So
Wonderful.
there's no issues with lactating patients.
Wonderful answer. Wonderful answer. Dr. George has a nice question. So what gauge needle do you recommend?
I usually use the 27, but
Right. So the good answer, this is not safety, right? So
okay.
what exactly, studies have shown that the gauge of needle has got no effect when you feel pain. So whether you use 25, you use 27, or you use 30, it's exactly the same amount of pain that people reflect. What dictates pain whenever you inject is two factors. Is that how fast you inject and the temperature of the solution. That's why if you actually, I always joke about it, if you ever work up north in Alaska, you will just basically find up the dental assistant rubbing up the local anesthetic cartridges in their hands so they can warm it up so the patient wouldn't feel the pain. So which needle gauge? If you ask anybody who knows safety, they will tell you they use gauge 25. Why is that? Because it separates and breaks less. Thicker the needle is, the less chances that you're going to have separation of needles. And believe me, there is nothing worse than a separated needle in your cheek, trying to look at it, and it migrates, right? It swims, it's got wings. Dr. Hussein, okay, thank you for the presentation. It's a tricky one, Dr. Osman. Thank you for the presentation. Which LA to use if the patient is allergic to sulfa?
So
You better answer that one.
that's a great question. I actually know the answer to that. So you would use a plain local anesthetic, which doesn't have a vasoconstrictor.
What?
I'm pretty sure. Isn't that correct?
What?
No? Okay.
Undergrad, on the second year of undergrad, and we studied biochemistry, and we started
Okay,
thinking.
never mind. Maybe I don't know the answer to that.
Sulfate. Is sulfa and sulfate the same?
No.
Exactly.
Okay.
The sulfa and sulfate are the same.
They are the same?
No, they're not.
No, they're not. Yeah, no, one of them is they're different molecularly, right?
Right. So if somebody's allergic to sulfa, why shouldn't you give him adrenaline? Would you? Would you give him?
Wait, sorry, if they're allergic to sulfa, you would give them.
You will give them any local anesthetic that has epinephrine?
No?
Why not? So I understand where the confusion is. So if you think about it, the agent is called metabisulfate.
Okay.
And
So if they're allergic to sulfates, then you.
Yeah, but the patient is allergic to sulfa.
Oh, okay, okay.
Sulfate are totally two different.
Okay.
So if the patient is allergic to sulfa, you will just give him regular.
Yeah. Okay. But if they're allergic to sulfate, then you give them the plain.
Right. And how would you know if somebody's allergic to sulfate?
Like an allergy test or history.
History of what? So usually where can you find sulfate apart from a local anesthetic? Food preservatives, right? So
yeah.
food colorings, like those orange, red, green food preservatives, those are the sulfates, right?
Mm-hmm.
So you have increased allergies to food preservatives, food colorings. And if we tell you yes, you will start to doubt. Which other category of patients you would doubt them? It's like last year again, right? Isn't it? Rose,
yeah.
Is it last year again?
Last year?
Right? Last year's again.
Sorry.
U of T again. Okay, now
minor details.
So it's Yeah, of course,
Yeah.
my dear, of course. So it's absolutely, and you know what? We have to not forget what is the purpose of these meetings. The purpose of these meetings is to educate each other of the questions that may arise, that could make us better clinicians, right? So another group of people that I would suspect that are allergic to sulfate are asthmatic people, right?
Okay.
Asthmatic people sometimes have got a higher incidence to be allergic up to sulfate. Those are the other category of patients that I would suspect. But that's what it is. And that's probably one of the nicest questions. So we differentiated between sulfa and sulfate, and we try to investigate who are the patients who could be allergic up to sulfate. And this is what it is. When you talk about toxicity as well, you remember that we have to think that there is two ways that happens, right, with toxicity. First of all, we will have more like a depressive, or are we going to be excited? So we'll have the excitatory phase, first of all, correct? So we'll have the sweating, the tachycardia, that the tachypnea, and then after that we're going to have the depressive status, right? So it starts to develop into respiratory depression, coma, right? So this is very important for us to differentiate, because not everybody goes through the two phases, but you will just be wondering, if somebody starts to sweat and loses up consciousness, but at the same time he's tacky, you just don't know what it is. Remember, you cannot always get up toxicity only by giving extra local anesthetic. You can get toxicity as well by intravascular injection, right? So you can get it by getting an intravascular injection. Dr. Rabia, thank you for the presentation. Does topical anesthetic with benzocaine cause an allergic reaction for patients with ester allergies? What do we use in the dental school?
It
Topical anesthetic.
was xylocaine 5%, I think. Yeah.
So we're using lidocaine, right?
For-
Xylocaine is lidocaine, right?
Yeah.
Right, but we're not using benzocaine, right? So Rabia, it has been reported, but I don't think if it is very wide or not, but it has been reported. The rule of the thumb is that if you believe that the topical anesthetic can be going into the mucosa and goes deeper to find up some blood vessels that it can go to it, then you can assume allergies reaction to it. This is how simple it is. So whether you're like me, believe that it's a myth, that topical anesthetic is a myth and doesn't work, or it doesn't work that deep into the tissues, or versus it does work, this is what it is. So the theory, yes, it can cause up an allergic reaction, but in reality, how many people have we all seen that? I personally haven't seen a lot. And obviously there are people who are allergic to esters, but I honestly did not see quite a bit. And thank you for pointing out the 3 local anesthetic that have an increased higher incidence of methemoglobinia as well, which is always good to remember what they are, which, believe it or not, is articaine, procaine, and benzocaine. Just like another always thing. Thank you very much, Dr. Saati, for mentioning those 3 drugs in specific, because a lot of us right now goes to those continuing education where they go ahead and try to talk about why articaine is superior and why you can do it and all that stuff. And we remember as well that given injections with higher concentration local anesthetic will probably increase the risk of giving paresthesia, right?
Mm-hmm.
Okay. So, you know what, it's always better for us to remember that there is a recommendation not to give a 3 and a 4% local anesthetic solution as a block. Actually,
So
this is
articaine, I think, is contraindicated as being given as a block.
absolutely, absolutely. And this is something for us to know. Dr. Hassan, I totally agree with you. If you go into articles right now, I actually was looking into meta-analysis, the British Journal of Maxillofacial Surgeries. There's somebody looked, believe it or not, on giving just a buccal injection of articaine to extract up an upper molar without the need to, to give a palatal injection. We don't know for a fact that there is a lot of basically a lot of literature when it comes to endo, when it comes to peds extractions, when it comes to articaine. Yes, it does give you more profound anesthesia. Yes, it is sufficient, but again, would you like to give an articaine to a child? Remember that methemoglobinia has got to do with the body weight. So, it's something for us to realize that. And again, I always do believe in the golden standard. I do believe that lidocaine is still considered as a golden standard of local anesthetic. And our ability to give and deliver a block whenever we use a block, and knowing our anatomy is the most important thing. So our anatomy, is that what dictates what we do? If we know how to give a block, if we understand the anatomy of all the teeth and what innervates the teeth, then we'll be able to achieve profound anesthesia. If we understand that PKA only affect onset, we're not going to be driven with the fact, oh, the tooth is too hot. I don't wanna touch it. Here you go, take some antibiotics and come out. All you probably have to do is just to wait a little bit more, because the onset of lidocaine is about 3 to 5 minutes, right? So it's something for us to remember all these things. Do I have articaine? Yes. Do I use it quite a bit? Extremely rare. Do I know people who use it every time and swear by it? Yes. But again, that's a clinical decision that you guys, I'm sure that you're able to make your own decision about it, but it's got nothing to do with the standard of care. According to the articles, the standard of care right now, or the golden standards of local anesthetic, still considered to be lidocaine, up to date, right? So other people use articaine? Yes, they do. I hope that answered the question.